Hi, my name is Wilson from EHA Education, and today we have Professor Domenico Girrelli to talk about the new classification of hemochromatosis. First, Professor Girrelli, can you introduce yourself?
Yes, I am Domenico Girrelli. I am Professor of Internal Medicine at the University of Verona with long-standing experience in treating patients with disorders of iron metabolism, especially for hemochromatosis.
Okay, so to start, can you give us a brief explanation of what hemochromatosis is to those people who don't really know this?
Yes. Hemochromatosis is a distinct disorder genetically determined by mutations that disrupt the regulation of iron metabolism by the hepcidin. Hepcidin, as you know, is the master regulator of iron metabolism, and it controls ferroportin, and by controlling ferroportin, it controls the iron entering the body by duodenal absorption and also iron recycling from macrophages. And mutation that leads to a lower hepcidin level, relative hepcidin insufficiency, leads to hyperabsorption of dietary iron that finally results in iron overload accumulation in different organs. It is actually a systemic disorder that involve many organs, in particular the liver, but not only the liver, also the pancreas, the heart, other endocrine glands, and so on. So these are the main features of hemochromatosis. I would like to stress that it is a distinct genetic disorder, and it's different from other types of iron overload disorders.
Okay. And you've recently written an article on the classification of hemochromatosis. Can you tell us a little bit more and why there was a need for that?
Yes. We have a panel in the International Bioiron Society in order to have a new classification more simple than the previous one. The previous one was based on the molecular defects, and it followed a type numeric nomenclature that included also the rare forms due to mutation in hepcidin itself, mutation in transferrin receptor 2, and hemojuvelin, that are very rare conditions that are diagnosed only at referral centers. So the main aim of this new classification was to simplify genetic hemochromatosis in two main types. That is HFE related, that is the most common type of hemochromatosis, that is seen very commonly in hematological center or internal medicine center, and distinct this form from the non-HFE group that is diagnosed at a referral center, in order to improve the communication between the general hematologists and the referral centers, because it is a little bit complicated to go into the molecular details in the rare forms.
So now there was a shift from molecular, purely based on molecular diagnosis, to a mixture of clinical issues.
We put emphasis on the clinical diagnosis.
Okay.
The clinical diagnosis is based on some laboratory values, especially high transferrin saturation, higher than 45%. That is the most important laboratory values, more than ferritin, because ferritin is very variable, and it can increase because of many different disorders. But the mainstay is increased transferrin saturation, and the clinical features are due to liver involvement, to heart involvement, arthropathy, diabetes, and so on. I have to say that nowadays the full clinical picture is rarely seen in clinical practice because a lot of patients came to consultation because of hyperferritinemia. But hyperferritinemia is a very, it is very common, and many different etiologies for hyperferritinemia, so you have to distinguish the diagnosis, and especially to check at first on transferrin saturation. Okay.
Yeah. Okay, so that's a clinical issue, is the pictures. And for molecular diagnosis, is it still the same as before?
Yes, yes. But we, in general, yes, but we made some change, especially in the former type 4 hemochromatosis that was ferroportin disease. Indeed, we can observe two different types of mutation in the ferroportin gene, gain of function and loss of function. Loss of function mutation in ferroportin gene are different from hemochromatosis because transferrin saturation is normal. This is the main feature. Otherwise, gain of function mutation in the ferroportin gene are responsible of hepcidin resistance. So even if there is no deficiency of hepcidin, there is a resistance of ferroportin to hepcidin, and then the clinical picture and laboratory picture is the same as other form of hemochromatosis.
Okay, so you now excluded previously type 4A and 4B.
Yeah. But this was a misleading classification, and very difficult for people that are not specifically involved in this field. So we try to simplify, and actually in a non-referral center, type ferroportin disease can be distinguished because of the lack of increased transferrin saturation.
All right. I forgot. Hold on. Okay. There was a question I was really wanting to ask, who I just forgot for a bit. It doesn't come back. We can edit this. So yes, with this new reclassification and classification, how does it impact patient management? The diagnosis, does it do?
Of course, management, an appropriate management depends on the correct diagnosis. Yes. So our aim was to simplify the diagnosis and also to make possible diagnosis only on a clinical ground in order not to delay the proper treatment until molecular analyses are done. This was the first aim, because, for example, in Italy, but it is almost the same in Europe, only few research centers can do the molecular analysis in non-HFE hemochromatosis. So the purpose of distinguish HFE, that is the most common type that can be diagnosed at every center, because you have just to check for one mutation, the C2A2Y in the HFE gene. It is very easy to detect. But otherwise, other mutations need to be screened by next generation sequencing and other techniques that are not available sometimes.
And with, so you say that hemochromatosis is a very complex disorder, and you're still finding new genetic disorders, mutations.
Yes, because we know that even when we apply NGS for the diagnosis, we still observe a few cases that in which we don't find any mutation in a known gene. There is space for other genes. Actually, there was a very interesting paper in last year in Blood from the group of Martina Muckenthaler that was able to describe another type of hemochromatosis due to mutation in the PIG-A gene. The clinical picture was a little bit different because there was also a neurological involvement, but it is just an example of other unknown genes that may cause iron overload.
Okay. And how prevalent is this disease, hemochromatosis, and what do you advise the clinicians?
We have to distinguish the prevalence of the mutation, the common mutation in the HFE gene, that is very common in the general population, up to 10% in Northern Europe, especially in Ireland and in northern France, and near 4% in the Mediterranean countries. This makes that the genotype is common, but the penetrance is very low. Only a minority of homozygotes for the common mutation in HFE develop the disease.
Okay. And do you have any advice for clinicians to do patients or diagnosis based on this new reclassification?
Yeah. Because whenever they found a patient with an increase in transferrin saturation and hyperferritinemia without any other possible explanation, it is very simple to prescribe the HFE test, and if positive, the diagnosis is made. If negative, and the suspicion is of non-HFE, you can refer the patient or the DNA, with not necessarily the patient, to a referral center.
Okay.
So our main aim was to ameliorate the communication between referral centers and general hematologists or internists or other specialists.
Great. Could you say something about the treatment for hemochromatosis?
Yes, treatment of hemochromatosis is in general very simple and is based on phlebotomies, regular phlebotomies, and that are generally well tolerated by the patient in order to deplete the increased iron stores. We distinguish two phases: the induction phase, when the phlebotomies are performed every week or every 10 days, and after achieving iron depletion, that means that ferritin levels are between 50 and 100 micrograms per liter, you can proceed with the maintenance phase that is variable in different patients, but generally they need 2 or 3 phlebotomy per year. This is the standard therapy, okay? And now we have a few patients that are intolerant to phlebotomies for a number of reasons. So this is still a sort of unmet clinical need, because iron chelators are not approved in hemochromatosis, and there is an increasing interest in hepcidin mimetic drugs.
Yeah. And
they can represent a future option. They are already in study in polycythemia vera.
Yes.
There are very interesting preliminary results, and I know also about a phase 2 study with an hepcidin mimetic in hemochromatosis. in order to decrease the iron stores without phlebotomy. There are very promising results, but we need confirmation for a consolidation with more data. And I would also recommend to check for organ damage in these patients, because of course if there is an endocrinopathy or osteoporosis or other complication, you have to treat appropriately the complication, especially in patients with advanced liver disease that need a very strict surveillance for hepatocarcinoma. That is one of the most deadly complications of hemochromatosis.
Just one last question. What are the life expectancy of patients with this disease?
Yes, life expectancy is normal in patients that can be treated by phlebotomy. We don't have actually randomized control data because it's an ancient therapy, of course, and we don't have RCT, but we have a lot of indirect data that support the fact that patients that are treated have a normal life expectancy. So this is very reassuring. Of course, it depends on the stage when you make the diagnosis. If the diagnosis is late, when there is already liver cirrhosis, it could be a little bit shortened, the survival. But nowadays it is very rarely observed because a lot of patients came to the ambulatory because of high ferritin, not because of symptoms. So,
okay, thank you.